So this panel is titled Making the Case, Bringing Reach Out and Read to Leadership. Now, we all know that convincing our leadership to invest in early literacy initiatives can be challenging, but it's not impossible. So with the right messaging, data, and clinical stories, we can make a clinical case for Reach Out and Read as a vital part of patient-centered care. So this panel today is going to bring together an incredible group of experts who are going to share their success stories with us, their cost-benefit strategies, their practical tips on how to communicate the value of Reach Out and Read to decision makers. And I know that it is going to be an amazing conversation and hopefully a really great learning opportunity for everyone involved. So now I'm thrilled to welcome all of our panelists. We have Carlotta Sanchez, Dr. Mary McCord, Dr. Suanne Kowal-Connelly, and leading the conversation today is going to be Susan, Olivera. She is the Senior Program Manager at United Hospital Fund, and she is going to guide us through the conversation today. So thank you all for joining us, and Susan, I will pass it to you.
Thank you, Megan. So good morning, soon to be good afternoon. Welcome to our panel, Making the Case, Bringing Reach Out and Read to Leadership. My name is Susan Olivera, and I'm a Senior Program Manager at the United Hospital Fund. And there I am responsible for managing and overseeing the development and execution of programs and projects within our Clinical Community Partnership Department. Today, I will be moderating this important conversation. As many of you know, convincing upper management to invest in early literacy initiatives can be a challenge. But with the right data, as Megan mentioned, and the right support, it is possible and powerful. So just to pause there, I wanted to share that in 2022, here's some pictures, UHF launched a 3-year initiative to partner and empower pediatric primary care practices in communities facing socioeconomic challenges and to improve child health outcomes and academic achievement. During the project's 3-year run, if we can show sort of the graphic, we worked with 13 providers and practices throughout New York City. One of them is here. Actually, both of them are here because we had 2 New York City health and hospital sites. And we provided one-time unrestricted stipend to support these activities, culturally and linguistically appropriate books for each site. So we know a little bit about this and we are very passionate about it. So moving on. As we were saying, with the right data and support, today we will hear from leaders who've actually done this work and can offer real-world strategies to help you make the case at your own institutions. So let's begin with brief introductions. I've asked each one of our panelists to share 1 or 2 minute overview of their unique role and perspective on implementing Reach Out and Read. So we'll start with Dr. McCord, Carlotta, and then Suanne.
Morning, everybody. So I'm Mary McCord. I'm a primary care pediatrician, and I worked for 25 years in the New York Presbyterian community-based practices, and then for the last 10 years, through last week, I worked at health and hospitals in their community-based practices, the FQHC network known as Gotham. I retired last week, but this is kind of the tail end of that story. At New York Presbyterian, I was involved in 1997 in establishing Reach Out and Read at the 5 or 6 offsite practices where pediatrics primary care happens at New York Presbyterian. And in coming to health and hospitals, working with Carlotta and with a large team, we built a program called 321 Impact. Reach Out and Read is part of that program, but the goal of it is to integrate Healthy Steps, community health workers, Reach Out and Read, and the Video Interaction Project into early childhood primary care, making relational health and the pediatrician's unique position in supporting relational health the core, really the core population health outcome that is valued and supported by New York Health and Hospitals. I'm not sure who is Carlotta. Is Carlotta next?
Carlotta.
I go.
There you go.
So thank you. Good morning, everyone. Again, I'm Carlotta Sanchez, and I'm the Assistant Director of Early Childhood Operations at NYC Health and Hospitals. In my role, I support the transformation of pediatrics primary care across our system, and currently I'm helping 30+ practices in implementing and sustaining advanced primary care models and nationally recognized interventions to include Reach Out and Read. I'm super honored to be here today with this group and thrilled to be a part of this conversation. Just to piggyback off of what Dr. McCord was saying, working within a large city health system, we're always trying to balance how we offer the most meaningful, equity-driven care while also being mindful of the time, staffing, and budget constraints that we face, right? So to that vein, Reach Out and Read is this amazing tool because it's not just a literacy program, it's one of the few interventions and initiatives that serves to, as a strategic and scalable tool in supporting child development. And it also is an opportunity for the providers to strengthen their relationships with parents and reinforce preventive care. But first, in order to do that, adopting a program like Reach Out and Read, you have to garner that buy-in from leadership. And that really requires clear planning. Leadership wants to see that there's structure and sustainability baked in because adopting new programs isn't without its challenges. So today, I really hope our discussions help, talk to leadership, but definitely framing it that it's in addition to things and reinforcing the things that you're already doing right for your families and your practices.
Thank you. Suanne?
Yes, good morning. And I just want to echo what everyone on the panel has already said, how honored I am to be here and spend this time with you and talk about our experiences in bringing Reach Out and Read and what I like to refer to as a culture of literacy to our organizations. So, I'm a pediatrician. I have been working for more than 30 years in pediatrics, and this later chapter of my work is in our FQHC, which is Harmony Healthcare Long Island. We are one of the very few FQHCs on Long Island. We might be the only FQHC in Nassau County. We have 6 health centers, freestanding health centers, 5 of which have full, robust pediatric centers. We have 3 school-based health centers in neighboring high schools. And one of the, important challenges that I think we've all already expressed is how to have leadership where you work in a multidisciplinary center, as FQHCs are, where pediatrics is often very low on that totem pole of importance in leadership's, eyes, although they pay lip service, I think, all the time to the importance of supporting the success of children. When it comes to actually putting those dollars in, I think that, the return on investment in pediatrics is just not quite the same as other disciplines, and we get sort of pushed to the bottom. So talking about how we can make that happen, I think, is really front and center and so important. So I hope that we can discuss that together and give you some great ideas and share our experiences.
Thank you. I want to take a 30-second pause to acknowledge Dr. McCord. Everyone is wishing you well on retirement. Ever since I entered this space, particularly, I hear your name all of it. So I think we all echo congratulations on your retirement. I wanted to sort of acknowledge that. So it's clear that there is no one-size-fits-all approach to securing leadership buy-in. I was also an inaugural Reach Out and Read coordinator many years ago at the Ryan Center in the Upper West Side, and it just happened to be that it fell within the purview of my role, my job. But that's not always the case for all locations, whether you're in FQHC, a private primary care, but there is one common principle that does work across all systems. And so we're going to do a deeper dive into those strategies. So just to frame the position and buy-in, let's start with the big question, right? What does it look like when you approach leadership in a way that makes Reach Out and Read feel like an opportunity and not a burden and something else that needs to be done, right? And so how do you frame early literacy? I think, Carlotta, you mentioned this a little bit, as being part of patient-centered care, not an add-on, not an extra. And how do the support structures, and how does the support that is structured differently compare between a larger and a smaller system? So I think, Carlotta, you mentioned how, H&H uses infrastructure to already integrate those programs without necessarily overwhelming staff. Can you speak a little bit more on how does that framing help secure support?
Right. So I think I have a couple of slides. So those are not my slides there.
I think that's the last slide of ours.
There we go. Here we are. So first I'll
Mm.
start by, giving you some descriptors of health and hospitals. It's the nation's largest municipal health system. We operate over 70 patient care locations across the 5 boroughs of New York City, employ 45,000 healthcare professionals, and we serve upwards of 1 million patients each year. We're comprised of 11 acute care hospitals, 29 and counting ambulatory care satellites, 5 long-term care centers. These are skilled nursing facilities, and a vast network of community-based and specialty care clinics. Within that, all 11 of our acute care hospitals have Reach Out and Read, and 17 of the 26 ambulatory care sites that house pediatric primary care already have Reach Out and Read programming. We're looking to expand to the remaining 9 by the end of 2026. So we're really invested in Reach Out and Read at Health and Hospitals. We've really embraced Reach Out and Read, not just as a literacy initiative, but also as a strategy that aligns with our core mission, right? It deepens patient engagement, it gives providers a meaningful tool for connection, and it drives measurable improvements in health equity and early childhood development. And we see that in our long-term benefits. That's what's displayed on this slide. Reach Out and Read boosts provider joy and morale, especially in these high-volume clinics. And what's also makes Reach Out and Read especially appealing to leadership is that it's a low-lift program, right? It's fully manageable within our existing pediatric workflows with no need for major staffing changes, right? Which is super important, right? Because often we're understaffed. And the data backs this up, from national participation to our own reporting that we do internally. Reach Out and Read improves outcomes and supports quality metrics like HEDIS and QAR. It's also aligned with broader system level goals like the New York State First 1,000 Days of Medicare initiative, right? We've actively tracked state level discussions around potential reimbursement, such as the VBP and alternate payment model planning, which could make the sustainability case even stronger and eventually, become reimbursable for these programs. So Reach Out and Read, as a pediatric initiative, it often serves as an entry point for deeper family engagement, connecting families back to wraparound services like mental health services, social work, care management. All of that is really important. And this is an opportunity to do those things. And it ultimately fosters meaningful change. Next slide. And so when you're expanding Reach Out and Read across a large system like ours, the key is to manage the growth thoughtfully. We found success in developing a scalable implementation framework that allows each site to tailor the program based on their panel size, their staffing structure, their physical layout. So systems that are seeking to implement reach out and read across multiple sites should really consider developing some kind of a scalable framework that's tailorable and that enhances program continuity. Epic integration has been a game changer for us also. It standardizes how and when books are delivered, embeds reach out and read into routine documentation, and helps us track meaningful data over time. So, think of Epic integration as a model. There may even be other opportunities for things like Epic smart sets or embedded literacy prompts to further simplify provider workflows. But, here at H&H, we've taken it one step further. We developed documentation tools like the reach out and read dot phrase and checkboxes under the anticipatory guidance tab to make the process seamless for providers, right? It's right at the point of care. And our system level dashboards allow us to monitor the reach and the impact and collect data for progress reporting, demographics, everything that's quantitative, insurance coverage, visit volumes, book distribution, and it's all in one place. So centralizing things, really creating infrastructure that not just supports the program delivery, but also continuous quality improvement efforts, really helps make the case for sustainability to leadership. It makes it stronger. Reach out and read dashboards really, have made it possible for us to do things like, monitoring the equity, collecting all of that data for the reporting twice annually, track volume patterns, and, really ask, are well visits and book delivery aligned, assess for fidelity, like identifying practices that need retraining or support. So what you're seeing on the screen right now is just an example of our reach out and read dashboard, which we're in the process of refining. And it's also showing that dot phrase that we built in Epic, as well as the checkboxes under the anticipatory guidance tab. Having a centralized team like the one that I'm a part of really allows us to create some level of standards around these programs and makes it easier for sites to implement, right? If we start with a handful and it's very successful, we're able to expand to additional sites. So really just like to sum all of this up, reach out and read, it can be something that's foundational to your early childhood programming and really serve as a launch pad. By embedding reach out and read across the majority of our practices, we're laying the groundwork for broader transformation in peds primary care, especially as early childhood interventions become like more central to payments and state policy. So thank you.
Thank you, Carlotta. I think everyone's excited to learn about the Epic tools. Just embedding things into the process. I know it's a lot of work sort of in the back end, getting it all in, but then, from a user perspective, it'll facilitate any, the use of it. So just thank you for that sort of framing in terms of how to really make it part of your workflow, correct? And so Suanne, I know you, in even prepping for this conversation, you've been a champion around building a culture of literacy, right? Which I think is so important because, when you reach out to staff and, hey, this is something else we're doing, everybody either rolls their eyes, oh, okay, now I got to do something else. But when you really create a culture and environment where it itself invites providers to engage and even staff, I know you have a nice really story with one of your facilities people too. Can you just share how that cultural shift has worked at Harmony Health and how others might replicate it, even if it's just a little small step?
Sure. I think the slides are probably a nice addition for this discussion, this part of the discussion. You can move ahead. ahead. So just to reiterate, you know, even in a small setting, Carlotta is talking about a very large system. In our small system, we also have the challenges of how to start the conversation and how to bring the idea of starting a culture of literacy within our institution and why that's important. For all the reasons that Carlotta has talked about, the fact that it isn't just a cute little corner or a cute little addition to the waiting room, it's actually creating the culture of something greater, something foundational to children's health and well-being, something that tells people from the moment they enter the door that this is important to us. This is something that we see as front and center for child success. And it says it not just to the children and the parents, but it says it to our staff. It says it, we say it to each other. We're basically creating an environment that speaks all the time about what we see as something that will basically be a launching point for children to have the greatest opportunity for success in their lives. So as that pediatric leader, I think this is really, you know, what I see as one of my most important responsibilities is to talk about the evidence-based guidelines that really back up this type of work. Next slide. And just as Carlotta said, even in the small setting, we have to really talk numbers to leadership. They understand about the first 1,000 days, and they understand about the successes that can either make or break. And they're sensitive to it and they care about it. But bottom line is, you know, how much is it going to cost and how much is it going to upset the apple cart? And all of the things that Carlotta said are so true, that this is something that really doesn't upset the apple cart. You can embed this right into your system and nothing really has to be altered or changed. It really seamlessly integrates and just creates a wonderful environment. And we can talk about all of the metrics that we have to meet, and everybody understands about, you know, all of the HEDIS and QAR measures that have to be met, and how this putting Reach Out and Read into our centers only increases our opportunities to make that happen. And that's been shown over and over again. The data supports that without a doubt. What's really beautiful is that we can also talk about attrition. And that's something that leadership really cares about too. They care about keeping staff happy, keeping staff engaged, keeping staff as staff. We suffer a lot with our attrition. And when staff become excited about a new experience, a shared experience, something that they can relate to, something that they can be involved in. You know, it's one thing to look at something from afar, and it's another thing to be engaged personally. So everybody engages in this. Staff get involved. Staff come and give children books. Staff come and work with the kids in this culture of literacy that I wanted to bring to our organization in order to really cement our Reach Out and Read program. So I'll show you some of those pictures. And before I do, I just want to make this one important point. Thanks to the wonderful funding from United Hospital Fund's Pediatric Literacy Project, the cost for this was incredibly economical. So even if you didn't have the great funding that we did, $311 per site is probably something that's in everybody's budget. But the bottom line is that it's very easy to do, and a little goes a really, really long way. And I just do want to say thank you to the United Hospital Fund for supporting the work that we did. It was really came at the most wonderful time, just as we were accepted into Reach Out and Read. So it all just became a wonderful labor of love to build this culture of literacy with, you know, throughout all of our sites. So next slide. So this is at our Freeport site. And you can see here's Hempstead. This is Roosevelt. This is Westbury. These are our reach out and read, little corners where our stock is kept, very easy, sometimes just in a cabinet, really easy to organize, doesn't take a lot of work. Usually whatever you have on hand can work and work well. This is just a close-up of what it says, in the decals. Reading will take you everywhere. This is just some extra stickers to put in the clinic area, areas that were just empty, areas with no life, really no personality, very little, creates an environment that makes everybody smile and makes everybody happy. And the truth is the staff were so happy about all of this, all the staff, the clerks, the pediatric providers, the medical assistants, the nurses. It just makes people happy. And that's not to say anything about how the families, the parents and the children responded to having all of this available to them. When we think about the staff also, keeping them engaged, having that fun stuff really makes your day so much brighter. So we all want to keep the fun stuff high and the tedious stuff low. So in the same vein as creating some of the tools in Epic, we have ECW. So just to show you, I'm able to actually manipulate ECW myself. So I know that Epic is considered, the leader in electronic medical records, but ECW has its own benefit in that it's very easy to manipulate, and I can actually build structured fields myself. So when we started Reach Out and Read, I was able to put into our preventive health section a little structured field that could be clicked, at any visit, and then brings in this little smart phrase. Next slide. And there you have it. The providers really have very little that they have to do. They just have to remember to click that box, and then the phrase is there, and we can collect our data. And just like a big, giant hospital system, we can also collect our data on all our different metrics and supply our information twice a year. It's not that cumbersome. It's really very manageable, even for a one-person team like mine, where a lot of the work is being done by me and then my staff supports, but, it works. So I think that everyone out there, from the small centers to the big centers, can think about implementing their own system to make this happen and make, beautiful, wonderful environments where families, children and staff all thrive together.
So this is fantastic. So for those of you who are asking, other than Epic, so thank you, Suanne. We couldn't have planned that even better. Just one point of clarification in terms of the the cost. Just for clarification, it was $311 per site to establish a literacy corner.
Correct.
That's sort of like the larger budget. So I wanted everyone to understand that that's really in creating that space, what that can be like a one-time cost. Just quickly, is there, Carlotta or Mary, if an example of maybe of one of your waiting room transformations, or just a little bit about culture and environment, a couple of minutes that you can share from your experience at your sites to this point?
You're on.
You're on mute.
Yeah, me and this pesky button. So I think one really amazing thing that we have is the Arts in Medicine program. It's an initiative that integrates art into healthcare settings, right, to promote like healing and enhance patient and staff well-being. And as part of this program, what has happened is NYC artists have been creating murals and displaying their artwork throughout our facility and campuses, with murals and art installations specifically commissioned for many of our PEDS practices reception areas. So we have these beautiful murals And these art pieces represent the rich cultures of the communities that we serve, and we're able to also engage the children and their families. So in some instances, community members and staff were able to be part of creating this artwork. So it's very meaningful in many ways. And I think that's one amazing opportunity that we have for, beautifying and creating these literacy-rich spaces for our patients.
Fantastic. I didn't know that. I only knew some, but I didn't realize it was across the system. That is amazing. So of course, cost and sustainability, right? Like we all want to know, how much is this going to cost? How much does it, really mean in terms of dollars? So, Mary, maybe you can help break down real world numbers. Is it 2,000, 5,000 annually? How to position that in what will be seen as a manageable investment on the leadership part. I think you've got some slides on that.
Yeah. So of course, the cost depends on whether you're talking about a system-wide implementation or a site implementation, though you really have to think of, if you're in the system-wide implementation, you have to think at both levels. I'll get to specific numbers in a minute, but thinking about those two levels is important. So what we're calling here the foundational level would be starting Reach Out and Read at one site. So you're going to implement you need to figure out, and all of this is easily available from the Reach Out and Read program, but that you need to figure out how many books you need, and a system for storing them, and a inventory system, and a system for getting them to the room, so that the provider, when they're in a busy day, can find the 6-month book and the 21-month-old book easily. And that's really probably the biggest administrative challenge for Reach Out and Read, is the maintaining the book inventory in a way that it's accessible to the provider. It's not that hard, though. It's not that different from making sure that every room has throat culture swabs and tongue depressors, and they small and large ear looker thing additions that we all use. So the first challenge is understanding that it's not that different from other types of inventory and distribution, and working with a team in administration to figure out how you're going to integrate it into that management. And often I think people do start with a Reach Out and Read champion who's managing that process, but you're going to have a more sustainable process. And you really should make your case to administration that this is how it should be done, that it's just like it's essentially like ordering another piece of small medical equipment that you're going to keep in the rooms, that has to be managed in a professional way. You can't only have 6-month books in the room. You have to have the right distribution of books across the room. The argument you're making at the site level is similar to the one that you're making at the systems level, that you're going to the extensive and well-documented data that Reach Out and Read improves developmental outcomes, it improves parent-child interaction, and what it's going to appeal to a lot of administrators is that it improves the HEDIS and QAR measurement. But I think also, even if you're only working doing this at a small site, it's important to think on the larger level. And as we've heard earlier, I think in this conference, relational health is becoming recognized as the core focus of early childhood pediatric primary care. That we're really in an exceptional position because we're the only system, so to speak, that systematically sees children through that early childhood period. When in the school age, when you're looking at how to impact population outcomes, you have to think of school as an alternative to doctor's offices, because children spend more time in school, they all go to school. But if you're thinking about the early childhood period, you only capture the families, and we capture them in a way that we really have the family trust. That was one of the geniuses of Reach Out and Read, when Barry Zuckerman and Bob Needleman and team were initially imagining this program, realizing that opportunity that was there in pediatric primary care. We need to now, in order to make the financial case, be expanding that out to say that it is the primary population that we're working on. We give immunizations to prevent illnesses. We manage a few chronic diseases like asthma. But most of what we do, and especially in early childhood, is promote early relational health, developmental outcomes, and supporting parents so that they can be the best parents that they can be. Reach Out and Read was the first, I think, the first that I was aware of program that talked about how we need to just integrate this into the day-to-day primary care, and that's a very doable thing. And it's, if you think of it that way, it's not very expensive. And I am going to get to the cost of the books in a second. But if you look at it at the larger scale, and this was mentioned earlier by Carlotta, many different sites are implementing not just Reach Out and Read, but also Healthy Steps, also community health workers in the early childhood period, also developmental screening in a more systematic way with closed loop referrals and making sure that that happens. We need to start as pediatricians naming that as our primary focus, that where in adult medicine, the primary focus is controlling hypertension, controlling diabetes, and preventing deaths from those illnesses. In early childhood primary care, the primary focus is a multi-pronged approach to support parents to be the best parents that they can be. That argument is taking hold. And if I'm not, it's a whole nother talk to talk about how that happens. But if you look into the literature, especially in the last year on pediatric value-based payment and advanced primary care models, that's what it's talking about for the early childhood period, is how do we shift our focus to long-term outcomes, cross-sector outcomes, and to modest investment towards these more long-term outcomes. And it's especially convincing if you're working at a system level to do that with, I think, with the multifaceted programs at in New York State, at the state level. The First 1,000 Days Initiative, with which some people are familiar with, had a Reach Out and Read specific pilot. The state now is thinking about how it could implement Reach Out and Read reimbursement. I don't think they're close to a model for that right now, but they're definitely thinking about it. And they're also thinking about the same thing for Healthy Steps. And we may be closer to a model for state Medicaid funding for Reach Out and Read, or at least we were before January. It's hard to say what's going to happen in the next 6 months. So next slide. So going more narrowly again, to talk about the cost analysis at the site level. And you have to, again, system level implementation, you're thinking about multiple sites. How much is this going to cost? One key fact is in New York is that Reach Out and Read for Greater New York provides 50% of the books that you need. And this really is if you think of the administrative aspects as something that should be just integrated into the teamwork of pediatric primary care, then the cost is the books. Half of the cost is covered by Reach Out and Greater New York, Reach Out and Read. But it's really more than half the cost, because they cover half if you look at your total number of primary care visits in a year at your site. Say that's 2,000 primary care visits at a kind of medium-sized pediatric practice. You're probably not going to give books out at 100% of visits, because we are generally fail to do 100% at anything. So I think the well-performing sites give out about 80% of the visits. You have to work at making sure that people keep up their enthusiasm for Reach Out and Read in the 3, 4, and 5-year-old age group. And given that, so now you're down to 80% of your 2,000 visits. That's a smaller number. The cost of the book supply is going to be small, and for that 2,000 visit practice, that 2,000 visits in the 0 to 5 age group at $350 per book, it's under $5,000 for the total cost of additional books of books. And so you're going to be able to find that funding again, as Suanne said about the environment enhancements. A lot of times that can be absorbed into the budget, and if not absorbed into the budget, organizational auxiliaries, if your site has an auxiliary, that's the kind of thing that they love to fund. And the development office of your organization can connect you often to small grants, family foundations. When I was at New York Presbyterian Hospital, I'll make this story brief, but it's a good story. When in the late 1990s, Reach Out and Read is a new thing. I went to as a young pediatric attending in the Columbia primary care system, to the Ambulatory Pediatric Association, it was called meetings, to the Reach Out and Read training session. I learned about how to do Reach Out and Read. I got the manual. I was leaving, and Perry Class called out to me and said, "Hey, Mary McCord, aren't you from New York? We have a funder who can fund your whole I think it was $50,000, your whole program." I was not expecting that, and so wow, that's really amazing. So I went back and we enthusiastic. We figured out how we were going to set this up across all the sites, and then it turned out that funder didn't really. They preferred Bellevue. Bellevue was in Midtown. They could send volunteers. It was going to work better, so they gave their funding to Bellevue. So we had done all this work and we didn't have our funder established. So we were a little disappointed, scrounging around. Someone knew somebody at JP Morgan Foundation funding, so I went down to talk to them, and they told me this is not something we fund. As I was leaving there, I lived in Manhattan pretty much all my life, but I don't think I'd ever been to Wall Street before. And Wall Street is very impressive. There's power architecture is all over Wall Street. So I went to a school picnic after that with my daughter. My daughter, who's now teaches third grade, was probably in third grade at the time of this picnic. And I went to the picnic. I was telling the story of going to Wall Street and the power architecture. I'd never seen that before. And somebody asked me, well, what was the program? So I described the program, and that person had a connection to a family foundation that funded, and I think they still fund, the New York Presbyterian Reach Out and Read program. And they fund most of their book needs beyond the greater New York. But so my point, that was lucky, but there are lots of family foundations out there. They are looking for small, concrete things with good stories to tell to fund. Something that's in the $500 to $5,000 range. You're going to be able to fund that if you can't do it through your auxiliary, usually with the family foundation. And then of course there's other types of partnerships. The key message, though, as Carlotta said, it's low cost, it's a high impact initiative, and it's aligned with long-term system goals. If you think narrowly, like HEDIS and QUAR measure improvement, but also long-term system goals. If you think at the state level, what's pediatric value-based payment going to look like? I think there's a lot of arguments for sustainability.
Thank you, Mary. I love the long-term sort of outlook as well. A lot of the communities that we serve have families that children do not have what we would traditionally, their own little bookcase and their own library. And so this program also meets those needs as well. When we talk about long-term exposing children, I think the data is out there to literacy early on, that bonding, right? That early relational health. So I think we can go on and on about sort of that long-term effect and the value of this amazing program. But thank you for really bringing it down to dollars and cents. I think that's what people want to walk away with. How can I translate this into dollars and cents? And so we're actually running a little tight on time, but I do not want to be remiss and miss sort of a data outcomes question, which I think we talked about a little bit already, and around just the satisfaction. And so how do those metrics resonate with leadership? So what other data points have worked for you? And how do you communicate the return on investment? Because I know you spoke that a little bit already, Mary, but just if Suanne or Carlotta also want to jump in, sort of how to sort of wrap up this conversation, what is that last point that you really want to communicate in terms of why this matters, and what is the return on investment for leadership that might be like, why is it worth it? Suanne, Carlotta, Mary again.
I think maybe Carlotta might be able to talk more towards data that she has already, because our program is so new. We joined Reach Out and Read just, earlier this year. So we have not yet, we don't have that data that is universal, but the data exists. Even if it doesn't exist in my organization, the data for supporting Reach Out and Read is very clear in terms of well child visits, immunization rates, developmental screenings, identifying maternal depression, identifying it early, getting help early. These are all things that are front and center. This is what, drives the practice in staying afloat. So the fact that these things are aligned is critical. I maybe Carlotta, you have actual numbers that in your own center. I hope that I will have actual numbers that will echo the national statistics on this, but they are very clear.
Compelling. Carlotta?
Unfortunately, today I do not have numbers. We definitely collect data in a different way that really supports the sustainability of the program. And once a year we do try to report out on engagement and things like that. But we definitely see it in our patients, right? The children that return and they're speaking more words. That relationship between parents and children, how excited parents are to get a book that they had when they were a child and say, I didn't think about this book, and now I have an opportunity to share this with my baby. So I think there's plenty of evidence beyond just the data that lets us know how wonderful Reach Out and Read is and what a benefit it is to have in our pediatric practices.
And I'll say, I think leadership is convinced by that those stories are very helpful. Specific stories of families or just testimonials from people that would Reach Out and Read, and then backing it up with data that's available from the Reach Out and Read website and their research section. There are so many studies that are well designed and that really show that patient satisfaction is improved, provider satisfaction is improved, mother-child interaction is improved, reading is improved, developmental outcomes are improved. I think if you show that data and then tell the stories, that can be convincing. And we do have for our integrated program, the 3-2-1 Impact Program, data that shows that we have higher rates of immunization and higher rates of on the HEDIS and QAR, particularly dental scores improve. I think just because we're more attentive or patients are more attentive to us. Dental visits, the number of dental visits and that dental QAR score, and then the adherence to WellCare visits, so meeting the 5 WellCare visits that are needed across the early childhood period.
I also want to say that it also promotes the cultural sensitivity that we have in our centers. We feel very strongly about that. I feel very strongly about trying to be culturally sensitive and trying to relate to my patients. I've been learning Spanish over a 3-year period, trying desperately to speak with my patients directly. And when I give them a book that's in English and Spanish, I don't think of it as such a big deal anymore. But their eyes, they're so excited that the book is, in their language, also in English. And some of my patients don't speak English. So the fact that they can learn English while speaking in Spanish, they just think this is fantastic. They're very touched. You can just see, and that's so heartwarming. It's sort of a little heartbreaking at the same time, to see what a big deal this is, but it is. And again, this builds relationships. It builds relationships between us as the center of their care. And I think that's also very important. I don't know about everybody out there, but I find that patients today don't take pediatric care nearly as seriously as they did 30 years ago. Maybe that's because I've been doing this so long. I can really talk to the difference. When I started in pediatrics, the anticipatory guidance that we gave and the things we taught our families, they would hang on every word. Now some patients are like, why am I here? They don't take the advice and the care that we put into trying to help them build relational health, help them support the growth of their child nearly as seriously. And I think that this program just adds to that sense of, just helps us build those relationships with families, helps us bond with our families.
I think it's very important that, and I think in summary, that, early literacy is integral to education. And we know that education is a social determinant of health. And this is what we're doing, is really laying the foundation for long-term academic achievement. When I was a Reach Out and Read coordinator, I was a young mom, and I even put out published a commentary on reading, how it's a family affair. It really is, brings everyone together. Children love books. I had moms that say, I don't know how to read. Well, your 9-month-old doesn't know how to read yet either. Just take that picture book and make up your own story. And so I think, just, in summary, really, you guys have presented an amazing argument that we can just customize and form our own ways of trying to get leadership buy-in. I think there's if anything, very few things they can refute, because I think between the research, the evidence, the quantitative data, the qualitative data, I think it all marries that this is a win-win situation for all around. So I know we're going to do a couple of questions now for Suanne. There's a question from the audience that says, how do you tackle interior design / infection control departments on creating your literacy-rich areas, also known as JACO? Just like, I guess people want to know, how do you work around creating those spaces also post-COVID, which has been a challenge for some practices as well?
We're not a hospital setting, so we don't have to conform to quite the same stringent rules. So I don't want to say that everything that I did in our sites is JACO, consistent, applicable. But everything is washable. I certainly made sure, I'm certainly very dedicated to making sure that we keep everything clean. Everything is washable, can be removed easily, replaced. All the furniture is washable. The rug, everything is washable or can be vacuumed. So just like any other surface, I mean, we have surfaces everywhere, just like any other surface, everything can be kept clean.
I like how you had the books at a higher level. I think the environment things I've been involved in, we tried to put things down at kid level, and that's just impossible to keep up with the kids. And
well, we battled with that, Mary. So we actually talked about that. Do we want to put it at kid level? And we decided, okay, so yes, it's wonderful to put it at child level, but these aren't necessarily things that we can afford to have everywhere. So we tell the parents to pick a book, and if the children see a book that interests them, please take the book. And all those books were given to us by our United Hospital Fund partners. And so they are our extra books that can be taken home. So everybody is invited to find a book that they love and take it home, or take two, bring one for your sibling. And we purposely did make them a little bit higher. So
I just wanted to add one thing, and then I'll just, over to Megan. In terms of the book cost, the books that Suanne is speaking, and even to the two sites at Jacobium or Sania, who also participated in our 3-year project, Books for School was fantastic. We were able to order in bulk, and the more you order, the less the amount. The diversity of topics, we even had some on mental health, or emotional wellness. How do I feel when there's a baby in the house, or if I get nervous when I go see the dentist? So Mary, I was excited when you said even your dental. We had an oral health project for kids as well. So just a little plug in for that. And then just, I think in terms of the 1,000 days and potential reimbursement, I know that North Carolina is a little bit ahead of us in terms of reimbursement and incorporating Reach Out to Read into their Medicaid payment structure. So hopefully New York is not too far behind there as well. So I just want to say it has been an honor for me to moderate this panel, to thank Suanne, Carlotta, and Mary for their insights and experience. I'm just going to pass it over to Megan. If there are any other questions from the audience, please either raise your electronic hand or submit a question through the Zoom chat. I know we still have a couple of minutes remaining.
Thank you, Susan. You were such an amazing moderator, and thank you everyone for sharing everything. I mean, I'm learning a lot, and so it's been really, really insightful. So thank you. We've been gathering some questions too on the back end. So I guess we'll start with What are some common objections or challenges that you've encountered from leadership regarding early literacy programs, implementing Reach Out and Read, and how have you addressed them? So I know you talked a lot about what kind of gets them over the hump, but what are some of the obstacles that you've seen?
Well, one obstacle I've seen at a few different places is administration is not pediatric focused or pediatric knowledgeable in general. And so they don't really understand the structure and the goals of the program. We would frequently get requests to give books to the emergency room to give out, or give books to the dermatology clinic to give out. And, developed almost a stock response of, that would be great to give out books in the emergency room or in the dermatology clinic, but it wouldn't be Reach Out and Read. Reach Out and Read is a structured program that's evidence-based. And so I think that emphasizing that it's not just giving books out like a lollipop, and it's not just giving a nice educational gift, so to speak. It's part of a structured program that includes the counseling that they get, and the selection of the books and along the developmental trajectory, and culturally appropriate and language appropriate. I think that's a key thing. And then the second thing I would mention is that, we talked about it needs to be integrated into the pediatric workflow, but we all know, I feel like pediatricians get asked once a week to integrate a new thing into the workflow because it's so wonderful for children. And so you have to get past the initial appropriate resistance, that you can't just ask us to add more things. We're doing so many things already. So there's a time that it takes, and it's why you need champions to build confidence in the things that we all know and that we've all talked about how important the program is. It's one of the few evidence-based things we do in pediatrics. Immunizations have more evidence, but there's not a lot else we do in pediatrics that has more evidence in pediatric primary care, more evidence than Reach Out and Read. And you can say those things, but you really have to build on it with the stories and over time, and show that it's easy. Carlotta, the work at a systems level that Carlotta's done, going in, working with sites, adapting the program, say, we don't have a space to store books. So figuring out a solution to that problem with the site, being patient. And you need champions to do that over time.
I just want to add to that point. Your champions can vary, right? Because nurses talk to nurses, pediatricians talk to pediatricians, and that front desk clerk, that's the first one that sees that patient. If they're excited about it, then everybody else jumps in. So just think in terms of champion, not just that. Thank you, Mary. Not just that pediatric champion that you need to fill out the Reach Out and Read application, or do the multiple champions at multiple levels, because you will see, how it translates and comes across.
I can also share with you a story about just trying to motivate your staff to stay engaged in Reach Out and Read, because you first introduce this new project. Of course, yes, you get all the groans about, well, what am I going to have to do? How much work is this going to take? And I showed you that, building a structured field where they just have to click that they gave out the book is really all they have to do, besides being engaged in the process, the integrated process, and understanding that and working within that framework. So when we started, everybody was excited and we started doing everything. I looked at some of the data myself. I went into the charts and pulled up the data of who's doing what. And I saw that some of our providers were doing a yeoman's job of giving out the book all the time. And then some really weren't. So what I decided to do, and I had to think about this long and hard, but I decided to share the data at a quarterly staff meeting so everyone could see how everyone was doing. And there it was. We have 10 people.
Keeping up
We've
with the
got
Joneses.
5 who are like amazing. And then we've got like another group who are sort of like not doing anything, it seems. Maybe they're not clicking in the right place. I don't really know what's wrong with them. And people in the meeting started saying, oh no, I don't understand. I love this program. I'm doing this program. I was like, okay, well, maybe you're just not clicking the right way, or I don't know. But next quarterly staff meeting, I went through all the data again and I presented it and I showed the before and after, and I had like green
lights, green highlighting for all the improvement. And everybody was like up to like 96% from like 40% to 90%. And it was really quite amazing. So the reward for that came for me many months later because I was very worried about doing this, but it paid off and I decided I'm going to use it for other things too. But I think, sometimes how you motivate your staff to stay engaged, there are different ways you can do that. That was one of my ideas.
Some friendly competition.
Yeah, that's a great idea. Nothing like keeping up with the Kardashians.
There you go.
Well, thank you so much, everyone, for this amazing panel. I know that this is very insightful and is going to help everyone in our network. So thank you for your time, Suanne, Susan, Carlotta, Mary, and I will pass it along to Karen.